Hi. Good afternoon. It's a privilege to be here. I have to confess that I had no idea what this meeting was about, but now I think I have a little bit of a better understanding. And welcome to Dallas, for those of you who are not from here. We're very lucky here to have Dr. Graves and Dr. Greenberg build their excellent team that takes care of these patients who really are very, very sorely in need of expert attention. The place where this comes into the treatment of these patients is essentially that my experience is in nerve reconstruction. I also do hand surgery and microsurgery. But in nerve reconstruction, we essentially deal with nerves that have been injured by either surgery or accidents, or even there are some babies that are injured at birth. And the place where this parallels some of the disorders resulting from transverse myelitis is that when there's an immune attack on the spinal cord in transverse myelitis, there is actually some collateral injury outside the spinal cord or inside the spinal cord to the nerve cells themselves that live there, that essentially are the nerve cells that keep the nerves outside of the spinal cord alive. And so the injuries that result from transverse myelitis in those cases is very similar to the kinds of nerve disorders that we take care of in patients who have had accidents where the nerves have been stretched or cut. So these are my teachers, Susan McKinnon, who's a world's expert in nerve reconstruction at Washington University in St. Louis, and Hanny Matlub, who is the best surgeon that I know in Milwaukee, Wisconsin. The basics of nerves that have been injured, and so this is kind of turning the page. We talked a lot about spinal cord and the brain today, but these are the nerves that actually are all of the nerves outside the brain and the spinal cord. And so all the nerves that come out of the brachial plexus up at the shoulder, the sacral and lumbar plexus down in the lower back. And so these nerves actually, in contrast to what occurs in the spinal cord or the brain, are actually able to be manipulated so that they can repair themselves. And so we can actually do surgery for these in a very clear way. That's something that's been described since at least the 1970s, where if we do reconstruction correctly and at the right times for these nerves, they have the ability to recover. And so what you see here is that when a nerve has been injured, say that it's cut in the middle of your forearm, if it's reconstructed and put back together, it actually has the ability to grow from that point where it's been cut and repaired all the way out to where it used to go in the fingertips and the muscles of the hand. And that occurs at a rate of about 1 millimeter a day or an inch a month. It varies some, but that's the general rule. The problem with this is that after a nerve is injured and the muscle has lost its nerve supply, that muscle has to get its nerve supply back within the first 12 to 18 months after the injury. And so we're really severely limited by time. And the reason is not really clear. It's a subject of a lot of investigation, but there's something that actually changes with the muscle. So if you have a muscle that's lost its nerve supply from a cut nerve or an injured nerve, and you wait 2 or 3 years, and then you come and you reconstruct it, the nerve grows just like it did the first day after the injury. It gets to the muscle, and when it gets to the muscle, there's something different, and the muscle doesn't work nearly as well as it would have if it had been reconstructed the first day after the injury. There are some reports that this can be stretched out to 36 months after an injury, but the conservative estimate is somewhere around 9 to 12 months. And so because of this, the reconstructions that I do in general have to be done within the first 9 to 12 months after the nerve injury in order to have hope of recovering muscle function. However, for sensory nerves, that's not true, and they can be reconstructed long after the injury. As many as 10 or 12 years have been reported. And so this is a kind of a picture of what happens to a nerve whenever it's injured. So if you take a nerve, this is the nerve cut crossways through. And so if you imagine this is a ribbon that goes this way, this is the middle of it. What we see are these bundles of nerve fibers, which are the orange, and each of those little nerve fibers is surrounded by myelin, which is something that's familiar to all of you as something that exists in the spinal cord in the brain, but it also exists in the nerve. And in the nerve, it's the insulation around these little nerve fibers as well. These are bundled up into what are called fascicles, and then inside of this outer sheath that's like holds them together like a multi-stranded wire inside of a conduit. And so if you stretch the nerve a little bit, the insulation goes away, and when the myelin goes away, it recovers by itself within 4 to 6 weeks, and when that happens, the recovery is complete. And so after some nerve injuries, when the myelin recovers, the nerve is able to go back to totally normal after a month or two. When the injuries are more severe, the wires inside break, which is the nerve fibers, and when that occurs, that's when the 1 millimeter a day or 1 inch a month recovery has to happen. And as the nerve gets stretched more and more, or the cut is more severe, different components of the supportive structures get disrupted. And when that happens, then it requires surgery in order to reconstruct these nerves. And so in the case of transverse myelitis, when those nerve cells die, then potentially all of this is lost because all the nerve fibers inside are gone and the cells that they come from don't exist anymore or are no longer working. If the nerve injury is less severe, where there's some inflammation to the nerve or an immune attack on the nerve, then potentially the wires inside break and they can regrow out from the spinal cord over time and recover function. And so this is kind of the way that it goes. Some of this is a little more technical. I'll skip through that. And so what we see here is actually what we face in the traumatic situation. When people have injuries, the nerves that come out of the spinal cord can actually tear out of the spinal cord completely, or they can break. And so this is a similar thing if you think about the actual nerve fibers inside the nerve that get disrupted to what happens after transverse myelitis. We look for signs of recovery on their EMG and nerve conduction studies. And then there are also some clinical signs that we use in terms of the recovery of sensation and the recovery of motor function. So the diagnosis of this is very important because we have to be able to tell the difference between nerves that are going to heal on their own and nerves that have to have surgery in order to be reconstructed. And so if you have a minor nerve injury where the nerves were torn, but they're going to grow back out into the muscles on their own at a rate of 1 millimeter a day or 1 inch a month, that may take, if you think about an injury that occurs at the spinal cord, in order for that to get back out to the fingertips, that could be a couple of years, 24 inches out to the end of the fingers, right, or more. And so during that period of time, we don't see anything happening in the hand, and that looks exactly the same as a nerve that's never going to recover. And if you wait 24 or 36 months until that nerve has function back, if you get to 24 or 36 months and say, oh, it looks like it's not going to recover, it's too late to do something. And so that's the role of a peripheral nerve expert, a nerve surgery expert, in order to determine that. And so in some ways, that decision-making process is more important than the surgery itself. We don't want to do surgery on patients that are going to get better on their own, and we don't want to miss the window of time for patients who are not going to get better on that own. And so it takes a lot of careful assessment. And so whenever there's an injury in the nerve, if we know that it's injured and it's never going to recover, then we try to repair it as soon as possible. Whenever we don't know, which is the case in some accidents and traumas and transverse myelitis especially, then we have to use the electrical findings, the EMG and nerve conduction studies in order to tell. And so that is what I would consider to be a spinal cord injury, as you guys probably know better than I do. And so in a spinal cord injury, there's a couple of things that happen. If the actual nerves that are inside the spinal cord get injured, then it's what's called an upper motor neuron injury, right? And so if the spinal cord itself is injured, but the nerves that go out into the arms or the legs are still okay and alive, then those can essentially be reconstructed far, far out from after the injury. If the lower motor neurons, which are essentially the nerve roots and the nerve cells that live inside the spinal cord, are injured, then we have a defined window so that the repair has to happen within the first 9 to 12 months after the event. And there's also a birth injury that occurs to the brachial plexus, which I'll show you here. And so this is the brachial plexus. The missing parts of this picture are the spinal cord is over here. This is up in the neck. And so these are the cervical nerve roots. And then this is the first thoracic nerve root, so the first nerve root that comes out next to the first rib. And these are all the nerve branches that go out into the arm and the hand. And so the major nerve trunks there are the axillary nerve that moves the shoulder, the musculocutaneous nerve that bends the elbow, the radial nerve that straightens the arm and straightens the fingers and wrist, median and ulnar nerves that bend the fingers. And whenever these nerves are injured, so these white spots are, injuries within the nerves, so that the nerve supply to the nerves that go to the muscles are disconnected, then traditionally what we would do with these, what you would consider to be electrical wires at this point, is actually place nerve grafts, which are splicing of the nerves. So the nerve is injured over here. It has scar inside the nerve, and it'll never get past there. And so we actually remove the scar or bypass the scar with these nerve grafts to redirect the nerve fibers so that they can grow back down into the muscles and to give sensation. And so the problem with this is that all of the repairs are very, very far from the muscles that they supply, because this happens up at the neck and the muscles are down in the arm and the hand. And this is what it looks like so after those kinds of injuries. And so if you go up to the neck and you look at the brachial plexus, this doesn't look like that picture, right? So this is after an injury, and all these nerves have been torn out of the spinal cord except for one, and it's very lonely here. And so this is a nerve rupture, and it's not connected to anything, so it's not able to supply the muscles that it's supposed to go to. And then what we see here is the spinal accessory nerve. It's one of the cranial nerves that allows you to shrug your shoulder. And this is the suprascapular nerve, which is one of the nerves that brings your arm out away from your body. And these are nerve grafts, which have to be used as the splicing material that are taken from elsewhere in the body, from the arm and the legs. And they're generally sensory nerves that can be spared, although the areas that they're taken from become numb. And so here's the nerve grafts in place. And so essentially you can see that they've been spliced across from the brachial plexus, that one single nerve root where there used to be 5, and these go down into the arm to return the nerve supply to those nerves. And then after this, it still takes 2 or 3 years for those nerves to regrow down into the muscles. Can you guys hear me okay whenever I'm there? Okay. And so this is what it looks like after one of these reconstructions. This was obviously during the 70s or 80s. And it takes years and years and years to get this kind of recovery. So what we can see is that he's able to bend his elbow. It's still severely wasted. The muscle's not great here in the shoulder, and it's kind of pulling out of joint, and there's probably not much hand movement at all after these kinds of reconstructions.
What was the initial injury in that?
So usually these are car accidents or motorcycle accidents, and what happens is that because the arm is so mobile and the neck is so mobile, those nerves actually get pulled on when the shoulder goes one way and the head and the neck go the other way, and so those nerves actually get torn. And so that's kind of analogous to the nerve injury that happens whenever you have transverse myelitis up in the cervical level. And so, if the immunotherapy is started in time, some of the spinal cord stuff recovers, but potentially those nerves are injured severely enough that they can't recover on their own. And so because that's not very satisfactory, there's been a big movement over the past 20 years, 15 or 20 years toward what are called nerve transfers. And so what we do in this case is actually, so you see the same kind of thing, right? So these nerves have been injured and there's scar here and they're never going to recover here. But what we've done is we know that there are parts of the nerves that are not injured that are still working. So this is the spinal accessory. It's the nerve that shrugs your shoulder. And instead of doing something up here at the neck, we go way down into the arm and the forearm. closer to where the muscles live, and so automatically whatever reconstruction you do is going to be way closer to the muscles. So the return of the nerve supply to those muscles is going to happen sooner. And so these are nerve transfers. And so here's the ulnar nerve. There's a portion of this that's redundant that supplies something that there are dual functions for, or more than one muscle that does this, or it's less important than the function that we're reconstructing. And so we can actually borrow from some of the nerves that move the fingers in order to restore the ability to bend the elbow. So this is the biceps and brachialis, which bend the elbow. Or we can borrow from the triceps, which straightens the elbow, and use that to help to move the shoulder so that you can bring your arm away from your side. And so this has really been a revolution in terms of the recovery that we're able to do. So in contrast to traditional nerve reconstruction, which is nerve grafting, we're able to do these reconstructions close to the muscle that's lost its nerve supply, which allows the muscle to recover its nerve supply faster, so there's less atrophy to a muscle because of that. And the donor nerves that we use, we know exactly what's in them. So the nerves that are up at the neck, you saw how they cross around all over the place. So a lot of the nerves that we're putting into muscles are actually nerves that are supposed to give feeling. And so when they get to the muscles, they don't really do anything. But if you know the muscle that you're taking the nerve from, you know that it basically only moves muscles. And so if you move that over to a nerve that's supposed to supply a muscle, then it's going to work a lot better to its intended purpose. And these are also in comparison to what are called tendon transfers, and some of you may have encountered this also. So there's a long history of the use of tendon transfers for both for reconstruction of the ankle and also for moving the fingers in patients who have had spinal cord injuries. And compared to tendon transfers, these essentially are more natural. And so when you do tendon transfers, you're borrowing from the same other muscles, except you use those muscles directly with their tendons in order to give movements back, instead of taking the nerves from those muscles and putting them to the muscles that normally do that motion. And so this is what a nerve looks like inside. And so if you look at it, there's all this crossing around. And so you may say there's this nerve here. Where is it over here? Well, this one is kind of over here, but if you look at this one, it's not in the same place throughout. And what we've learned about this as we've done more of these surgeries is that you actually can go inside these nerves and trace them out, so like that red line. And if you use a microscope and careful surgical technique, you can actually separate those nerves out. As you go down closer to the fingers from the neck, the crossing over gets less and less, so it's clearer what the anatomy is. And so this is a nerve, not in a human, but this is essentially a cadaver dissection. And so high up in the median nerve, there's a lot of this crossing. And so if you take this and you try to follow it back, it's like going through a maze, right? But as you go further down toward the hand into the forearm, they actually become very straight, and there's not much crossing over at all. And so this is essentially analogous to what happens in a ribbon cable. You can essentially trace it all the way back. And this is at the wrist, opening the carpal tunnel. And during surgery, this is what we see. So we open the outer jacket of the nerve, and we see what are called fascicles, which are those bundles that we talked about before. And so for the upper part of the brachial plexus, it essentially supplies the shoulder the ability to get the arm away from the side and also to bend the elbow. And so elbow flexion. So this is the first nerve transfer that was described in recent times. In the 40s, there was a surgeon by the name of Lurie who had described these, but essentially those surgeries fell out of favor when nerve grafting started in the 1970s. And so what this does is, this is actually less complex than what we see during surgery. So the nerves that supply the two muscles that bend the elbow, which have lost their innervation, get reconstructed by portions of the ulnar nerve and the median nerve, which bend the fingers and control the small muscles of the hand. And so during surgery, this is what we see. So here's the median nerve, and here's what's called the musculocutaneous nerve that goes to the biceps. And what happens is that we go and we look at those nerves. Here's the ulnar nerve, the other nerve that controls the hand. And we open those nerves up, and we actually find portions of them that are redundant, that are expendable. And we reroute them and essentially rewire the muscles that bend the elbow from the muscles or the nerves that supply the muscles that move the fingers. And so this is how we pick out what to use. And so during surgery, if you take this little nerve stimulator and you stimulate the median nerve, you can actually figure out what portions of them are muscles that you want to take and what portions of them are muscles that you can't miss. It's like a party trick. And so that was the median nerve, and here's the ulnar nerve, which bends the wrist and also moves some of the other muscles of the hand. And so you get the point, right? So based on this, we can figure out which things you can absolutely not do without and which things you can spare to get something more important. And so we do that during surgery, and after we reroute, after 9 months, they start to get some recovery, and after a couple of years, they can get really quite excellent. So this looks a lot better than the dude that was in the 1970s picture. And there's stuff for the shoulder, too, in order to get the arm away from the side. And so we borrow from the spinal accessory nerve, again, which is that nerve that you use to shrug your shoulder up. And also from the triceps, nerves to the triceps that straighten your elbow. And so the triceps is called triceps because it has 3 heads, right? And so because you have 3 heads to that muscle, there are multiple branches, and you can do without some of them if you have to, so that as long as you keep one of the heads of the triceps, you can still straighten your elbow, and you can use those nerves for something better whenever you can't bring your arm away from your body at all. You can spare the strength of straightening your elbow. And so that's used to reconstruct the axillary nerve. The spinal accessory, the shrugs your shoulder, is used to reconstruct the supraspinatus, which also brings your arm around away from your side. And miraculously, maybe because of intelligent design, these nerves are just long enough to reach the way that these transfers are designed. And so here's what it looks like. So here's somebody's shoulder. This is an incision that's made to go after the nerves up here, and there's an incision that's made down here to go after the triceps and the deltoid. And this was described by a German group. This is what the anatomy looks like in a cartoon. And so here's the real thing. So here's the nerve that you use to shrug your shoulder. Here's the nerve that brings your arm away from your side. And essentially, this is straight rewiring again that utilizes the biology of this. So this nerve is moved over to here. And that's what it looks like after it's been moved over here. And it's just long enough to do that. And down in the arm, again, we use the nerve to the triceps and move it up to the deltoid. And this is what it looks like down in the arm. So here's the axillary nerve that's been injured, the one that brings your arm away from your side, nerve to the triceps. And that's rewired up and sutured with really small sutures under the microscope. And this is the recovery, so the deltoid didn't work at all before. You can't really even tell which side was the side that was injured. And the arm, I think it's this side, that did not come away from the side of the body before now has the ability to go completely overhead. Some of it has to do with the age of the patient. The younger the patient, the better. Some of it has to do with the surgery, and some of it has to do with the injury. He's very proud. And he's been working those muscles very strong too. So you can see the scar here, but he's definitely recovered function where there was none before. Recent innovations have actually been using these techniques to allow us to reconstruct the motion of the fingers. And so these are some nerve transfers for radial nerve reconstruction that, again, use the median nerve, and the radial nerve is the nerve that straightens your wrists and your fingers. And so these are for brachial plexus injuries. Again, so if there are injuries to these nerves, regardless of what the injury was. And essentially the reconstruction techniques that we use for this is a nerve transfer form of what's used for tetraplegia. So for spinal cord injuries where there's partial loss of movement of the hand, tendon transfers have been described for a long time. You can see that there was already enough organization in 1978 to make a classification system. And so essentially what we're doing is, again, deciding whether you need surgery within the first 9 months and using EMG and clinical examination to figure that out. This was described by my mentor, Dr. McKinnon. And we're looking at the various functions of the median nerve that needs to be borrowed from, and picking out stuff that can be taken without a lot of loss of function in order to restore the ability to move the fingers and the arm. And so this is down at the elbow. Here's the elbow here, the biceps that bends your elbow. And then as you go down in the forearm, we actually find those nerves in order to do these reconstructions. And so essentially, again, this is straight rewiring, but you have to really understand what the anatomy is to do it correctly. So the median nerve, we take some of the branches that bend the fingers and some of the branches that bend the elbow, the FDS and FCR, and move them over into the posterior interosseous nerve, which is part of the radial nerve that straightens the fingers. And this is what it looks like in a cadaver dissection. So there's all these little nerves, that's the wiring. We have to figure out which ones are the ones that we want to take and which ones are the ones we want to keep, and move them over. And so here's, again, what this looks like. And so this is the median nerve where we go in and figure out what branches to take. And then we move those over to the radial nerve again, and which branches to take of that. And this is what it looks like. So again, there's just enough length on both of them to get where you need to go. And afterward, again, it takes 6 to 9 months. So this is interesting. So this is a case of a 55-year-old farmer. He was using a forklift, and what he was trying to pick up was heavier than the counterweight on his forklift. And so he flipped the forklift, and the counterweights actually hit him in the back of the head and stretched his shoulder and his brachial plexus. So he tore those nerves up at the neck. And when he had an EMG at the first time that I saw him, 5 months after his injury, so the time is ticking already, right? Because we only have 9 to 10 months to make this decision about whether he needs surgery or not. And we looked at the EMG, and there was no recovery in those muscles that straighten the wrists and the fingers. And so he was scheduled for a reconstruction. And so here's the forearm, the elbow here. And we also did a tendon transfer in him to give him the ability early on to straighten his wrists again. And here are the branches of the median nerve. And we essentially decide which ones to take that are partially redundant and move them over to the radial nerve that straightens the fingers. And there's the picture you saw before. Can you click this for me, please? Thank you. And so he didn't have the ability to straighten his fingers before, and so there's that in action again. And his hand's tight because it hasn't worked well for a while. But so before he couldn't open his hand at all. This is one more thing. So the anterior interosseous nerve is responsible for bending the fingers, and so this is actually something that's directly applicable to spinal cord injury patients, which are different from nerve injury or brachial plexus injury patients. Because often patients who have had a high spinal cord injury in the neck at the cervical level have maintained the ability to bend the elbow but don't have the ability to close their hand. And when that occurs, even years after the injury, we have the ability to borrow from the nerve that bends the elbow and move it over to the nerve that bends the fingers. This is something that's only started to be done in the last 3 or 4 years. And again, Dr. McKinnon was one of the people who started advocating for this. So, like I said before, this is applicable to injury to the lower portion of the brachial plexus, which is that network of nerves coming out of the neck, especially the branches that go and supply the fingers, and also for spinal cord injuries where the nerve tracts or paths in the spinal cord have been injured. And so the rationale for this is that the anterior interosseous nerve, which bends the fingers and the thumb, is the most important nerve to move the fingers when you can't move them. And because they're what we talked about before, the biceps and the brachialis, the two muscles that bend the elbow, we can borrow from one of them to switch over to bend the fingers. And so again, these road maps, so we take the nerve that bends the elbow and we move it over to the nerve that bends the fingers. And we're able to do that because inside the nerves, there's a reliable map of where those portions of the nerve run so that we know where to find them when we do surgery. And we try to do this within the first 9 months after injury. This is what that looks like. Again, similar. So the median nerve, we track up through the arm past the elbow, and then we move the nerve over. And it gives back the ability to bend the fingers. And she also had a tendon transfer to allow her to flip her hands palm up, which is much more useful for carrying things. Can you click that for me, please? There you go. So this is another case that's similar. So this was a young woman who was involved in a head-on motor vehicle crash and lost the ability to bend and straighten her fingers on the right hand, which is she had a wrist fracture on the other side. And can you click that for me, please? And she had a similar transfer and regained the ability to bend her fingers, and another transfer to allow her to straighten her fingers. Again, please. Okay. And because I'm a hand surgeon also, you can see that even though she can straighten her finger, this hand doesn't look normal, right? So there's muscle missing here, and this configuration is abnormal. And she's not able to get her hands around things because the small muscles in the hand don't work well. And so for that, I still resorted to the traditional way of doing things, which is using some tendon transfers, again, robbing Peter to pay Paul and borrowing from things that work to move things that don't work very well. And so this is what that looks like. So there's tendon transfers here to bend all the fingers together, and tendon transfers here to allow the thumb to come away to hold large objects like a cup. And tendon transfer here, borrowing from one of the muscles that bends the wrist down to get the thumb out of the palm. And a tendon transfer here, borrowing from something that bends the fingers in order to allow the hand to close in a more natural grip. And so here's her. Can you click that for me, please? So here's after. So that looks pretty natural. And little things. And so this is nerve transfers that I've used for transverse myelitis patients, as I've shown you before. And then finally, holding a bottle of water. It gets better, I promise. And opening the cap. Okay, and so we've also used these techniques for lower extremity. So again, for trauma to the nerve, the peroneal nerve is the specific nerve that brings your ankle up so that the foot doesn't fall down. It's called foot drop deformity, right? And we've seen this in patients with transverse myelitis who have partial recovery where the foot and the ankle can go down but not up. And it results in the foot getting in the way and tripping, and really impairs the ability to walk. And so this was first described, these types of transfers were first described by Dr. Nath in Houston in 2008, reiterated in the past couple of years by the group at Mayo Clinic. And here's what it looks like. So here's the knee. The common peroneal nerve comes down around the knee, and the muscles that straighten the ankle and the toes, and the muscles that roll the ankle out to the side, what's called eversion, come off of this nerve. And so when a portion of the deep peroneal nerve that brings the ankle up is not working and it causes a foot drop deformity, then we have to do reconstruction for that. And so there are a couple of options. We can use either the superficial peroneal nerve, if it's preserved, to move over. So you're borrowing from the muscles or the nerves that roll your ankle out to the side to the ones that bring your ankle up. Or you can use what's called the tibial nerve, which is the nerve on the back side of the calf that bends the ankle and the foot down. So you're actually taking stuff that bends the ankle and the foot down and switching it over to the nerves that bring the ankle up. And so this is a case where we use this technique. It's a 13-year-old girl who had acute transverse myelitis 9 months before I saw her. She had been treated with immunotherapy and with plasmapheresis, hospitalized for 2 months. And she developed a foot drop deformity, so her ankle was not able to come up. And she had a nerve conduction study, EMG, that showed that this was an L4, L5 spinal cord level injury to the cells, the nerve cells that live inside the spinal cord that keep those nerves alive. And she had reconstruction by taking from the superficial peroneal nerve, which is the nerve that rolls your ankle out to the side, to the nerve that brings your ankle up. And so this is what that surgery looks like. So we approach this from the side of the knee. Here's the kneecap. Ended up only doing the front part of this. And so here's the peroneal nerve. It goes this way to bring the ankle and the toes up. It goes that way to roll the ankle and the foot out to the side. And you can actually see that there's a problem with this nerve. It actually looks a little bit different and it's sick. And that's the nerve specifically that brings the ankle up. It's called the tibialis anterior muscle and nerve. And we borrowed from one of the nerves that rolls the ankle out to the side, one of the ankle everters. That's the peroneus muscles, and we switched it over. And after about 9 months, she started recovering the ability to straighten her ankle again. And this is at several years out. Can you start that for me, please? There goes the ankle. Okay. Sorry, I ran over. Thanks.